Assalamu alaikum.
Ramadan Mubarak to everyone. And thank you for joining us for today's grand round. My name is Samar Suwan. I will be moderating this grand round. And today's topic is an important one with the title Dry Eyes. It's one of the commonest pathology presenting to our daily practice. And I'm delighted and honored to introduce the presenter, Dr. Sabah Jastaneiah. Many of you know Dr. Sabah. She's working as a chairman of ophthalmology department and senior academic consultant in cornea anterior segment refractive surgery in specialized medical center hospital. Dr. Jastaneiah is an adjunct, also assistant professor in Al Faisal University. She has many publications in an index journals. She gave a lot of presentations at an international meeting, and we're happy to have her today presenting this article. She used to work here also in KCASH for almost 14 years, where I was honored to work and also be trained with her. She used to carry a lot of administrative responsibilities in KCASH, and she used to be an associate division chief and inspiring to many of us in the anterior segment division. And I would like to hear from all the audience by posting your questions into the question box, and we'll address them at the end of the presentation. Now, without further ado, I'll turn the mic over to Dr. Sabah Jastaneiah. Dr.
السلام عليكم. شكرا يا سمر. كل عام وانتم بخير جميعا. يعني جت هذه this presentation came on the first day of Ramadan, so I hope this is a good sign and an energy boost for all of us on this day. So let me share my presentation. Right. شكرا. السلام عليكم. So I have no financial interest in any of the material presented in this presentation. And as we started, I would like to congratulate everyone with the month of Ramadan. Ramadan Mubarak, inshallah. The time I was approached to give this grand round presentation, I thought of many topics really, but dry eye came to my mind, and I submitted the title because of what Dr. Samar says. It's a very common eye problem that is not really fully understood and not fully well managed. But then the association and the close relation between the dry eyes and the ocular surface disease make me change a little bit of the title to make it dry eye and ocular surface disease. Dry eye is a known diagnosis since the historical times, and xerophthalmia means dry eyes in the Latin in the Hippocrates time, where there was constant dryness in the eyes, is just a proof how long we have been facing this problem, and the treatment that was managed from oil to waters and replacement at that time of history. But then the importance of dry eyes is really not going to be not addressed very well by the ophthalmologist in general. As we can see in our practice, most of them are managed with the medication, the lubricant replacement, without the understanding of the actual pathology behind dry eyes. In addition to experiencing myself a little bit of dry eye from time to time, and this bit of sandy sensation, burning, affecting vision is really disturbing, and many patients come to the clinic really devastated of the dry eye, especially when it's moderate to severe dry eye. So in this presentation, we will be talking about 3 parts. The first part is the understanding and the definition of dry eyes. The second part will be tackling a little bit of the diagnosis and diagnostic tests. And then we will talk about a simple approach to the management. And here I would like to mention there's just a few of the new management strategies in this condition. So in 1995, dry eye was defined as a disorder of the tear film due to tear deficiency or excessive evaporation. So in this definition, the etiology was defined into 2 factors, which is the tear deficiency or the excessive evaporation, which causes damage to the interpalpebral ocular surface and is associated with ocular discomfort. So they have said that this is going to cause the damage to the ocular surface, and they associated it with symptoms of ocular discomfort. And that was the definition that lasted for quite a good number of years. This definition joined or make the diagnosis or the definition of dry eye same as keratoconjunctivitis sicca. And as we can see here, it is into two main categories of tear deficient and evaporative conditions and so on. But then the challenges that were in this division were addressed in the new division, the definition that came afterwards, which was in 2007. And here there was an address of the tear hyperosmolarity and the ocular surface inflammation in dry eye. That has and also that has an effect on the visual function. So this updated information were addressed in the a definition that came in 2007. That came in 2007, and here they defined dry eye as a multifactorial disease of the tears and ocular surface. So it is not only a disease of the tears and the resulting symptoms of discomfort, visual disturbance, tear film instability with potential damage to the ocular surface. It is accompanied by increased osmolarity of the tear film and inflammation of the ocular surface. So by that definition, we are addressing all the points that were challenged in the previous definition, including the causes, the discomfort, the effect on vision, and the two main factors, which is the osmolarity increase and the inflammation. That has a very important role later on that we can talk about in the management of dry eye. The three-part classification system that was developed the first part was addressing the etiopathogenic causes, which is illustrated the multiple causes of dry eye. The second addressed the mechanistics that shows that each cause of dry eye may act through a common pathway, and that any form of dry eye can interact with and exacerbate other forms of dry eye. So in this part, we are talking about the vicious circle of dry eye. The third is the scheme based on the severity of dry eye, and this was important in this stepwise approach to initiate the therapy of dry eyes. So in that classification, they talked about the etiopathogenic classification. They addressed here, in addition to the other factors, the influence of the environmental factors on an individual's risk development of dry eyes. And they called it the melo-interior and the melo-exterior, which is the conditions that will affect the dry eye through the environmental factors externally or internally, as in terms of hormonal changes, steering, computer use, and other factors that were addressed. The mechanistic factors are the, as we mentioned before, the correlation between the both pathways, the evaporative status and the aqueous deficient status, and how they form a vicious circle or a vicious cycle that interacts, and there is no starting point in each one of them. So each one of the cycle can lead to the other, and they integrate with each other. Then came the challenges of the 2007 definition itself. And those challenges were related to the distinction between the primary category of dry eyes. So dry eye were defined as aqueous deficient or evaporative. And in this case, as we mentioned before, the vicious circle between, or the vicious cycle between the aqueous deficient and evaporative status are not really distinct. So you cannot distinct the both categories from each other. In addition, the concern that the accuracy of placement of some of the conditions within the classification or the subclassification zone. That is, in cases of Sjogren's syndrome, for an example, the primary etiology may be aqueous deficient, but it has certainly a Meibomian dysfunction role that will also be causing evaporative status. So it is, you cannot subcategorize some of the conditions in one subclassification only. The third challenge in that definition was the level of specificity important to the dry eye diagnosis to avoid misdiagnosis of other ocular surface disease. As we all know that ocular surface and dry eye are causing each other, and again they are in a vicious circle, but we need to identify and make sure that we don't misdiagnose any of the conditions. And this non-specificity in diagnosis increases the risk of perceived treatment failures. And again, here comes the importance of differentiation so we can initiate the proper treatment in these conditions. So the revised report came, and that was 2017, redefined and reclassified dry eye, exploring all the items that were addressed before. And the report attempts to remove any perception of exclusivity in the classification of dry eye by indicating in the scheme that aqueous deficient and evaporative status exist in a continuum rather than separate entities. So we came to the diagnosis that we will follow from now on, and I will a little bit elaborate on this diagnosis because this is the understanding of this definition of dry eye is going to facilitate the way that we look at each patient who comes with this complaint, facilitate the way we examine, facilitate the way we treat later on. So the definition states dry eye as a multifactorial disease of the ocular surface. So now it is an ocular surface disease characterized by loss of homeostasis, which is the signs, and accompanied by ocular symptoms in which tear film instability, hyperosmolarity, inflammation, and ocular surface damage and neurosensory abnormalities play etiological role. So in this definition, everything is addressed from the disease as an ocular surface disease, the signs, the symptoms, the etiological factors, and the effect of it on the ocular function. And as we can see here, the part of the continuum status between the evaporative and the aqueous deficient. And as we all know that this Meibomian gland dysfunction or the evaporative deficiency basically forms 70 to 80% of dry eye condition. And the first thing that were mentioned in this definition is the management of the homeostasis, which is very important in this condition. Then the definition talked about the ocular surface, and I just brought this slide to show how important when we mention ocular surface and the ocular surface microenvironment in the management of dry eye. And as this picture illustrates nicely, the tear film with all its component, the role of the conjunctiva with the goblet cells, the inflammatory cytokines, the role of the blood vessels, the lymphatics, the corneal nerves, the central nervous system, the hormonal changes, lacrimal gland, the cornea itself, everything works together in a continuous environment that is called the ocular surface microenvironment. The definition also addressed the loss of homeostasis, and this encompasses the diverse range of signs that are possible with the ocular surface and tear film imbalance, and then talked about the accompanied by ocular symptoms, and this has been broadened to include symptoms that extend beyond those of ophthalmic discomfort, dryness, and visual disturbance. And hence, in this diagnosis the dry eye diagnosis requires the presence of both clinical signs and symptoms. The etiological factors that were addressed were to allow the differentiation between dry eye disease from other ocular surface disease. The key etiological drivers that predispose patient to the self-perpetuating vicious circle of the dry eye disease have also been included in that definition. So when we talk about the vicious circle or the vicious cycle of dry eye disease, we're basically talking about this continuum space between the evaporative dry eye disease and the aqueous deficient. The dry eye disease most commonly the result of the Meibomian gland dysfunction, causing hyperosmolarity, but there are other factors like the incomplete blinking and the aqueous deficiency that in turn causes inflammation and of the lacrimal gland and so on. And this again gives us the return to the vicious cycle or circle again. So this vicious circle talks about the tear film hyperosmolarity, for example, that is occur in both dry eye subtypes, can trigger multiple ocular surface inflammation cascades and pathways. The release of these inflammatory mediators can lead to the loss of epithelial and goblet cells, as well as damage to the epithelial glycocalyx pathway. The resulting tear film instability further exacerbates the condition, and so on. So from here, we finished the first part of our talk, which is the definition and understanding of dry eye. Then we will move to the second part of the talk, which is the diagnosis of dry eye. We will be talking about the diagnosis in terms of validated questionnaires and the ocular surface diagnosis in terms of clinical diagnosis or equipment that we can use to help in the diagnosis. But basically, this is like the history we are taking for our patients in the clinic and the day-to-day practice test that we are going to be doing. So, in this approach, if you can see, we took part of the definition of the dry eye disease, and we are going to address the diagnosis in terms of the triaging questions. Then after the questions, we will address, once you have asked the patient the questions needed, you will address the risk factors and you will analyze them. Those symptoms will be added to the signs, and then you will go to the subclassification to whether it is evaporative and the severity, aqueous and its severity, and then to the percentage of each contributing to the patient complaint. The triaging question or the questionnaire of dry eye, we have a dry eye questionnaire and we have the ocular surface disease index questionnaire, and we need certain number 5 of each to help with the diagnosis in addition to the signs. Example of these questions were address how severe is the eye discomfort, any mouth dryness or gland swelling, how long was it there, are there any triggering effect, vision, is it affected or not, does it itch, swollen, crusty, discharge, is it worse in the morning or accompanied by other symptoms, what about contact lens wear, are there any other health conditions? Are there any medications? So basically, this is what we need to ask each patient who comes with a complaint of dry eye, and addressing those questions will help us to really ask other questions of triggering factors that compute how long the patient works on computers, to assess the blinking rate, to assess hormonal deficiency, and so on. Then we come to the other questions, which is the ocular surface disease index questions, and those are addressing basically 3 important subclasses or subscales, which is the ocular symptoms, vision-related function, and environmental triggers. Once we are done with the questions and addressing the risk factors, then we will go to the second part, which is the diagnostic test. Here we are addressing the symptomatology. We're addressing the homeostasis markers. So when we say homeostasis markers, we are assessing the signs of dry eye, and it says better to be started in this way, which is starting from the non-invasive tear breakup time, like using the Myers to identify any interruption of the tear breakup time. It is less than 10 seconds, then it is diagnostic. Assessing the osmolarity, if it is more than or equal to 308 milliosmol per liter in either eye, or the intraocular difference of 8. Fluorescein breakup time then will be placed, and then ocular surface draining with 5 or more spots on the cornea, 9 or more spots on the conjunctiva, or what we call here the lid wiper epitheliopathy, which is staining of the lid margin of more than 2 millimeters length and 25% width. So these are called the homeostasis markers, or the signs that we can check. The Schirmer's test is no longer one of the important things that is addressed here, but just paying attention here that we do the non-invasive tear breakup time before we put the fluorescein, not after. Then we come to the aqueous deficiency, and we can measure this clinically by assessing the low volume of the tear meniscus level. If it is less or more than 0.2, 0.1, or absolutely 0, and there are certain machines that can evaluate this level. I have no financial interest in it, but it would be nice if someone is interested in the dry eye to have such machines to help follow up and help in the diagnosis of these patients in the mode of severity. Then we come to the Meibomian gland dysfunction. And from my practice and from my contact with other ophthalmologists, I've seen that this entity is not taking what it deserves from us in the clinics. And most of the concentration usually is on aqueous deficiency, not in Meibomian gland dysfunction, although we know that it has its big share in this diagnosis. So in the evaporative condition, the Meibomian gland dysfunction can be classified into mild, moderate, severe. And really, if this by itself carries a whole lecture separately, but I'm just going to address here 2 points. The morphology that we can use the infrared meibography, and then we have the gland function. I think one of the speakers, the microphone's on, Dr. Maisa. Gland function by applying gentle digital pressure. And this can be easily done in the clinic, really, when you apply digital pressure that you can express and see the Meibomian orifices and see if they are patent, clogged, and how is the secretion coming out of them. Diagnostic expression is different than gentle pressure. And then we have the directly assessing the Meibomian gland by the evaluator machines. So it is the most frequent cause, and here in the Meibomian gland dysfunction, other important factors are addressed. These important factors addresses the eyelid inflammation, the conjunctival inflammation, corneal damage, microbial changes, and dry eye disease resulting from this tear film instability. So again, we go back to the definition of the Meibomian gland dysfunction as an entity by itself. It's a heterogeneous condition arising from a combination of these separate pathophysiological mechanisms. This is an example of a normal lid margin with the nice distribution of the Meibomian gland orifices, and we can see each one of them. And here is a normal meibography showing the normal glands. This is, on the contrary, is a clogged clogged Meibomian gland orifices, as we can see in the first picture on the left, and then we can see the strings that can come with decompression, and this elaborates how severe is the dry eye dysfunction in this case. This is again a nice meibography picture that shows the normal difference between the normal and then the shrinkage of the gland and blockage of the Meibomian gland and their orifices. So the pathogenesis of both Meibomian gland dysfunction and dry eye disease can be described in terms of the vicious circle, as we mentioned, and the understanding of the pathophysiological mechanism of the dry eye and Meibomian gland dysfunction results in what we call as a double vicious circle. So when we talked before, we were talking about the vicious cycle or circle, and now we're talking about the double vicious circle that addresses the underlying pathophysiological mechanisms. And here is an example of it. The one we mentioned before was the vicious cycle, which addressed that the aqueous deficiency and the Meibomian gland dysfunction all share interact in common cycles, and the double vicious cycle, which addresses the pathophysiology. In both of them, you will see that there is no specific entry point and there is no end or beginning to it, and that's why these circles are important in the addressing the therapy of the condition. This diagram demonstrates part of the therapy that can be addressed, like the lipids replacement, hygiene, osmoprotection factors, the oral tetracyclates and antibiotics, the steroids as an anti-inflammatory, lid hygiene again is addressed here, and so on. From there, as we're talking about this vicious circle, we will be moving to the third part of this presentation, which is going to address the therapy and management. Most people with symptoms related to ocular surface disease suffer from variable combination of both abnormal Meibomian gland dysfunction and tear underproduction or aqueous deficiency. The estimated degree of overlap between these two categories, which we mentioned before as a continuum category, have ranged from 30 to 70 and sometimes up to 80%. So how we are going to address or to manage these conditions, and should we manage once we have defined, for example, that this patient is having tear insufficiency and is performing more of his dry eye condition, should we only replace it or consider that we need to extend more our management to include the inflammatory component and the other components that may indirectly cause the vicious cycle to continue even though we have addressed one part of the medication. This part of treatment or management of dry eye condition is going to be divided into 6 parts. It is not separate entities, so it is really a mix and match between different parts of this management, so you can address and target and custom made each management to address the needs of your patient. First category is those patients who suffer mainly from tear insufficiency and you need replacement or supplementation approach. And in this approach, we're basically talking about the aqueous supplementation or lipid. We're talking about the biological tear substitutes like the autologous serum, the adult allogenic serum, the umbilical cord, the platelet preparation, the mucolytics, and other antagonists of the receptors. So here we're talking about supplementation of the tear insufficiency. Then we're talking about the conservation approach. The conservation approach, like when we have a patient and we address the deficiency by applying punctal plugs, whether that is permanent or temporary surgical intervention. Then we have something called the moisture chamber spectacles. We can address that as here addressed in the pictures. And we can talk about the humidifiers. So we are talking about the conservative approach to the tear insufficiency treatment. Then we come to something else in the tear insufficiency treatment, which is the tear stimulation approach. And here we are addressing the aqueous secretogens or the mucin. In the aqueous, we have some products or drops here. Again, I have no financial interest, and I really don't have an experience with those drops, but it's worth mentioning because it is such presentations are eye-openers to other modalities of treatment and other things that we may target and approach to help our patients. And this is a Japanese medication that is targets the aqueous secretion. Then we have the lacritine, which we know as an eye protein, and they formed it in an eye drops that promotes healing instantly in experimental studies. We have the mucin secretogens, and again we have multiple products here. I don't have much of experience on many of them, but it's worth mentioning and knowing because managing such severe patients may require us to understand more and explore more other options of treatment. Of the tear stimulation approach, we have also the lipid stimulation, and here we have the insulin-like growth factor, The oral secretaceous, orally administered cholinergic agent agonist, like the pilocarpine and the 7-Mylene, which is commercially available for the treatment of Sjogren's syndrome associated dry eye disease. I know that at Kikesh we have quite a good number of patients with Sjogren's. At my times, we did not address this oral medication. I'm not sure if it is addressed now as part of the treatment of these conditions. Then we have the nasal neurostimulation. It's a machine that is very easy to use, interfacing directly to the nervous system through the electrical, electromagnetic, chemical, or optogenetic methodology. It is placed in the nostrils. This way of neurostimulation, what I understood from previous talks about it, that it is a promising way of replacing tears or tear stimulation approach. And then other methods, one interesting way I've came through is the abdominal breathing for 3 minutes. And then we have the corneal cold thermoreceptors, and then we have the caffeine. The second treatment is targets the abnormalities of the eyelid. And as we all know, the importance of the anterior blepharitis in the contribution of the condition, and how to manage it affects the dry eye condition management. So the lid hygiene, the topical antibiotics, the Demodex infestation, and this is, although it is compromising a lot of the patients who comes with blepharitis, but we still think that it is basically underdiagnosed condition, and the management of this condition, which is the Demodex infestation, could be by the tea tree oil or the ivermectin and other products, but it is not easy to diagnose. You really need to be very meticulous in looking at it, or sending the what you assume that is blepharitis scales into the laboratory in order to see such an infestation. Treatment of the Meibomian, of the lid abnormalities, again addresses the Meibomian gland dysfunction. Lubricants is one of them, warm compressors, and then we have other things that would help in the warm compressors, like the Blefasteam. I have few people who are using them, and they're very comfortable with the use. Other mask that will basically make like a warm compressor function. They have the infrared warm compressor device, and then we have the physical treatment, like the forceful expression, the lipoflow or the tear science. We have the intense pulse light. I'm recently having an experience with the IPL machine in my clinic. I'm using it in moderate to severe cases of Meibomian gland dysfunction, and we have really good promising outcome, very good satisfaction rate from the patients. And those are patients who are suffering from severe, moderate to severe dry eye with Meibomian gland dysfunction. Introductory probing by introducing a small device into the ducts, or debridement and scaling, which debrides the lid margin from those inflammatory components that resides on the lid margin. And so when you debride them, you create a clean ocular surface. And when I come across this, I really wonder if the way the kuhal placement at some people, when they do it, they really debride the lid margin when they're placing the kuhal, especially if they're placing it within the eye. If this has a role to causing a beneficial effect on the use of the kuhal by this way. The third part of the treatment comes into the corneal exposure. And this, I'm sure most of us have a good experience with it, as we face a lot of corneal exposure cases. The tear supplements, the ointment, of course, the moisture goggles, the nighttime eye shield, the mechanical closure of the eyelid, and so on. There's something called the thin polymer films, and those are placed. They do better than, according to the literature, they do better than the ointments and the lid closure. And they're like very thin films of polymers that are placed on the cornea. The contact lens has a therapeutic role, like the therapeutic bandage contact lens that we use. And again, like was addressed in the Saudi Ophthalmology Society this year, the role of the rigid gas permeable scleral lenses in the management of dry eyes. The fourth part, which is a very important part of the treatment of dry eyes, which is the anti-inflammatory component. The component, whether it is steroids or non-steroidal immunomodulators, like the cyclosporine, the tacrolimus, the non-steroidal anti-inflammatory, the biologics, and the neuropeptides. From what I'm seeing, if you're seeing a patient that is diagnosed with moderate to severe dry eye condition, then certainly there is a component of an inflammatory component in these conditions. And I guess the role of the steroidal or non-steroidal immunomodulators in this condition is very important to be addressed. You can have like a stepwise or stage-wise approach to the patients. If they are severe, we can start with the steroidal and then introduce the non-steroidal anti-inflammatory. If they are very chronic and require a very longer time of treatment, we can address the cyclosporine management and so on. There are other factors like the anti-inflammatory therapy, like the lymphocyte function associated antigen antagonist, and this is a good modulation because it addresses it antagonizes the receptor itself. The tetracycline therapy, systemic azithromycin or topical azithromycin therapy as an anti-inflammatory, again, are important factors to be addressed. Moving from the anti-inflammatory therapy, we go to the surgical treatment. This is usually, we reach that stage when it is a severe condition or when there is another factor contributing to the dry eye, like the lid condition, the exposure, and so on. So the treatment of the tarsorrhaphy, by tarsorrhaphy, the treatment of conjunctival chlesis, the blepharospasm, treatment with botulinum toxin, correction of the lids, the conjunctival surgery and amniotic membrane, and other more major surgery involvement to replace the lacrimal gland and provide more quality tear. Lastly, we're going to address the dietary modifications. These are important to address to the patient: the hydration status, the replacement with essential fatty acids, the lactoferrin, and other dietary modification in terms of having a healthy diet that contains all the essential requirements for a healthy body in general and a healthy tear film. Seventh is the local ocular environment factors. When we say about local ocular environment, we're talking about the microenvironment, and here we're talking the chronic topical medication. This needs assessment, whether you can replace to single dose medication, especially the anti-glaucoma. And we have seen many reports that came about the anti-glaucoma medication and how stopping them or replacing them affects dramatically the ocular surface and vision improvement. Systemic medication that affects the dry eye. The decrease in blink rate, like what most of us face in our clinics, of parents complaining about their children staying a lot on the computer, on the mobiles, and the decrease in the blink rate from 15 to 20 and to up to 5 or 7 times blinking. And then we have the other factors, environmental factors, and the contact lens wear. Complementary medications, the herbal and natural products, the honey, the milk, and the acupuncture. This is all in research and all in ancient medicine, but usually for myself, I would advise for natural products, but I don't have an experience with honey, milk, and acupuncture really. So, but it is mentioned in the literature. So in conclusion, we come back to the basic definition of dry eye. As from this definition, we're going to be addressing all the factors we mentioned. So it is a multifactorial disease of the ocular surface accompanied by loss of homeostasis, and accompanied by ocular symptoms. So here we're addressing the signs and symptoms of ocular disease, in which the tear film instability, hyperosmolarity, inflammation, ocular surface damage, neurosensory abnormality play etiological factors or roles. And from each of those etiological rules, you can address the therapy or the treatment for the most probable cause in the case you're having. And as we always do in medicine, the meticulous history taken, which resembles the questionnaire, the meticulous examination of each of the micro surface components or the ocular surface components leading to dry eye, the stepwise therapy, all can lead to better management of the dry eye condition. Lastly, I would like to stress on the role of the Meibomian gland dysfunction, and maybe this by itself needs a separate talk to help residents and others to understand how it is diagnosed, the stepwise, the severity of it, and how to manage it. And of course, at the end, we need to explore new diagnostic and management methods in the management of such a common condition of dry eyes. Thank you very much for being patient with me on the first day of Ramadan. كل عام وانتم بخير وإن شاء الله رمضان مبارك. Thank you.
Thank you, Dr. Sabah. We would like to hear from you by posting your questions into the chat box, or you can just unmute yourself and ask Dr. Jastaneiah directly if you want. Okay, so so far I don't see any questions, but I'll start by asking you, Dr. Sabah, like, you know, in our daily practice, whenever we have a patient, presenting for any cataract surgery and the patient is having a dry eye, could you tell us how important it is to address this before doing surgery, and what are the things that you do in particular to prevent any IOL surprises in these patients, and how do you manage them post-operatively?
Okay, that's quite a three-part question, Samar. So the first thing is the importance of addressing dry eye in patients going for surgery, especially the patients who are not really symptomatic. When these patients experience dry eye as part of a complication or part of the, let's say, some patients would have experience after cataract surgery, even if you're doing a very clean phacoemulsification surgery, some patients would have dry eyes after surgery. So it is important to address that before and consult with your patients the appropriate ways of management in this condition. So you won't be facing a patient who is not happy because you induced dry eye as he will be thinking after the phacosurgery. The second part is the importance of the tear film and the importance of the tests that we were doing before, like the K readings, like the IOL master calculation of the IOL when there is a good tear film and a good ocular surface, and this is going to impact the IOL calculation, so to avoid hyperopic surprises in the future. So it is an important role. Although we are doing a 2.2 incision, we're still maybe causing a temporary dry eye condition in such patients, and addressing that before surgery, managing the ocular surface problems, especially if there is Meibomian gland dysfunction, with the proper treatment is important before cataract.
Great. We have one question. How does hyperosmolarity cause the dryness?
As we mentioned in the slide, the hyperosmolarity affects the cells, and this could cause interruption of the cells and release more of inflammatory components, and then we go back to the circle itself. Any other comments or questions? Yeah, there is you. And then
Are you doing IPL even for patients with cicatrizing meibomian gland dysfunction?
Those with completely cicatrized or those completely blocked will not, in my opinion, maybe not benefiting much of it. But you never know if there is one or two. I don't have the meibomography, so I cannot judge if there are still some of those are functioning, but we cannot see how many are they, because this is one of the important criteria in the diagnosis of the severity, is to assess how many of those orifices or how many of those ducts are working. So in one patient, I have tried it, and to the surprise, there was a benefit from it. And the patient came after 2 weeks asking for the second session because she felt a good improvement on it. So yes, I would give it a try. It is harmless. It takes about 5 minutes, and it doesn't require a lot of work from both sides, but it's a good machine to use.
Great. Okay. And then what's your protocol for the IPL?
Usually we, once we address everything, of course, the time that takes the IPL or any interventional way we do in the clinic, the consultation time is the thing that takes time, really. So we come and sit and talk about it and stress that this is part of a management. It's not the whole management, and the importance of the continuation of other anti-inflammatory medication they're using, the lubrication lip replacement, or the stimulation ways. And then we do one, for example, today, the second one after 2 weeks, and the second one will be the third one. Session will be addressed 4 to 6 weeks after that.
So a total of 3 sessions.
3 sessions, yes.
Okay. And how would you, put the treatment plan? Would you start with IPL before starting other standard of care treatment, or you just delay it until response?
No, basically, I don't like to jump in treatments. So basically, I would, those patients whom I have done IPL for were patients I've been following for a while. I've tried different treatment modalities that would include even expression in the clinic, oral antibiotics, topical and oral antibiotics, and so on. So we reach this as kind of, if we go stepwise, this would be before the last resort or the last resort.
Great.
I seen Dr. Saeed.
Yeah, Saeed Keda.
Okay, you want to ask a question or raising hand?
Haven't seen any. You can unmute. Yeah, Abdullah Bilali is raising his hand. Yeah, you can unmute yourself. Unmute yourself, Dr. Abdullah Al-Bilali.
Okay. So as you mentioned, Summer, as long as there is no question now, when you talked about cataract surgery and dry eye, and this was one of the reasons I really selected this topic, because in each one of our clinics, regardless of the subspecialty we are in, we're facing this condition, and it has a direct and an indirect effect on our patients. For example, patient going for certain types of IOLs and how dry eye is going to affect the outcome. Patients going for refractive surgery, keratoplasty, even the improvement post-retina surgery, for example, when there is a total epithelial defect, improvement post-glaucoma procedures, post-glaucoma medications. So it is a topic that involves all the specialties of the ophthalmology, and that's why I wanted to address it and address the importance of tackling this issue, even if it is not the main specialty of that surgeon or that physician.
Yeah, I agree with you. It's very important really to know how to diagnose it properly or pick it earlier and before it's, you know, the patients are going to present with a worse scenario. There is one concern which I notice nowadays. There are quite a good number of patients that are presenting to the clinics who are, getting the non-steroidal anti-inflammatory medications, the NSAIDs topically from the markets, and they keep on using them for long period. In your opinion, what do you think the harm to the ocular surface if the patient is on this medication for, like, unnecessarily, indication by himself for allergy or just for redness or cosmesis?
Yeah, I'm sure you addressed this point just because of the resident attending of this lecture. Usually I dig a lot in the asking my patients questions about what medications you're using, and most of the time the first question is just lubricants, and then when you dig more and you ask them to show you and you ask them to describe the medication and how frequent, you will end up seeing that you're using a lot of those medications that we really don't prefer to use as long-term, but they don't think that this is a problematic thing for them, so keep using them. So we go back to the importance of questioning, asking specifically on certain medications. I agree with you. Those are harmful. Most of them, if some of them do not contain preservatives, but most of them contains preservative that by themselves can induce dry eyes. The non-steroidal anti-inflammatory have an aesthetic effect that can induce problems if they're long-term used. The steroids have their own problems. Each one of them has its own problem, and that's why the stepwise management and judgmental management in their use is very important. And the one important thing is not just to give it to the patient to explain the harmful effect if they were prolongedly used. Great. Did I answer your question? Was this?
Yes, correctly. Yeah, it's an eye opener to the residents because they frequently got a lot of patients presenting to the emergency room with this medication. So it's educating the patient about the harmful effect of chronic use of NSAIDs without proper indication is very important. Yeah. Any other questions or comments?
اوكي شكله الجميع صايمين اليوم.
شكله It's the first day of Ramadan. Yeah, thank you so much. So looking forward to meeting you all in person, inshallah, for another grand round with Dr. Jastaneiah in near future.
Inshallah. Thank you very much, and thank you for accepting to moderate this session, Samar.
Thank you. Okay. My pleasure and honor. Yeah. Take care.